Hello everyone, Dr.Jyotsna here. Namaste. So, I will be talking about how to manage a patient with intracranial hemorrhage. So, we had a case, a young male on CKD patient, hypertensive patient on maintenance hemodialysis. Last dialysis he had in the morning at around 6 a.m. he has completed his maintenance hemodialysis. Of course, he has received one heparin standard dose during that period, and at night around midnight, 12 midnight, he goes to washroom, and there he suddenly he shouts, and her wife goes and see that he is not able to he's not in good shape. He's like saying that I'm having headache, giddiness, and I can't stand on my own. So then she found that there is a right sided weakness, and she brings her on the bed and checks the BP. The BP is more than 230 by 140. She gives some antihypertensive medications and immediately bring her to our hospital. In emergency, they found that the patient is having slurring and right-sided weakness. So they immediately, and the BP was high. They gave one shot of Lobate and they shifted the patient to a CT scan and then informed us and shifted to ICU. When the patient came to ICU, we see that the patient, so what we have to do, how you will manage such patient. If a patient come to you in emergency or in ICU, first we have to see for if the patient is conscious, or like any critically ill patient, just while approaching to the patient, you have to see whether the patient is, how he is doing. Is he conscious or unconscious? If he is unconscious, BLS followed by ACLS assessment with primary and secondary assessment you have to do. If they are unconscious, you will see whether the patient is responding or not, and then you will go for the whether a pulse is there or not. So RBS, what is the RBS? So pulse and breathing is there. Patient is unconscious, RBS you have checked. You will check any tongue bite, then you will come for ABCDE and secondary assessment with the sample histories for the differential. So in airway, you have to approach a patient that okay, is the patient GCS is less than 8? Is there any sign of not able to maintain his airway patency? Like if the GCS is less than 8, of course you will have to intubate the patient to secure the airway. If the GCS is more than 8, but you see that there is a tongue bite, blood in the mouth, and that he may aspirate or he has vomited, the vomitus is in the mouth, so you may have to secure his airway. Or you find that is a bradypnea or tachypnea. So if any sign of the intubation is there, so you can go for that. So after airway, breathing comes. Breathing, generally I have told you that because of the Cushing reflex, there can be hypertension, bradycardia and bradypnea because of respiratory depression. So if required, you may have to so the patient may be in bradypnea or tachypnea because of some underlying metabolic disorder, or the patient is highly hypoxic because of the maybe underlying some disease, or because of the aspiration. You may have to support with oxygenation, or may have to intubate the patient according to, you can't put an IV in such patients. Then C comes. Generally there can be bradycardia or hypertension. If there is hypertension or bradycardia, so in hypertension, if the BP, whether the BP is greater than 220 systolic BP or less than 220. If it is less than 220, you have to bring down the BP to 140 to 150, and if the patient is stable. if the BP is greater than 220, then you have to first bring down to less than 220 systolic BP in another 1 hour, and then gradually decrease to the 140 150 in another hours. So but the patient should be hemodynamically stable. That you have to be cautious about, because sudden lowering can it may worsen the condition also. So just be cautious. But yeah, of course, in hemorrhagic shock, if it is a hemorrhagic shock, you have to, if it is a hemorrhagic shock, you have to control the BP, because it has shown the benefit in terms of functional outcome. Yeah, it may be possible that CT has not been done or brain imaging has not been done, and you don't know whether it is hemorrhagic or infarct. In that case, of course, plus you have to get imaging done first before doing anything about the BP, because in ischemic stroke you may have to keep the BP on higher side. Only you will intervene if you have to thrombolize the patient, and if the patient BP is greater than 180 and you want to thrombolize. Otherwise, if you don't want to thrombolize, even you have to accept BP up to 220. Or if there is no other sign of any hypertensive emergency, you may have to accept the higher BP. So first rule out whether it is see whether it is a hemorrhagic or ischemic stroke. If hemorrhagic stroke, we have to bring down the BP to 140 to 150. And there is an interact trial and also another trial. These trials, post honk studies has said that there is a functional benefit by decreasing the BP by 10 mmHg with each by decreasing the BP by 10 mmHg. So once you have ruled in that this is a hemorrhagic stroke and patient is stable, you have to bring down the BP to 140 to 150 as soon as possible. If it was initially less than 220, and especially in another 1 to 2 hours, and if it is more than 220, first bring down to less than 220, and then in another hours you have to decrease down as the hemodynamics and other patient's conditions permits. So in C, other than this BP, you have to take care of hypertension, bradycardia. So just keep watch for that. Do ECG also, because there may be chances of some other cardiac dysfunction because of the catecholamine release in such hypertensive bleeds. So there is chances of STT changes or concurrent some ACS like that. So you have to be cautious about that also. C and D. What is D? D is for disability. Most important. It will initially only you will come to know that while saying that is there any focal neurological deficit which has developed acute sudden focal neurological deficits in terms of hemiparesis, difficulty in seeing, vision loss, or difficulty in speaking. So these are the sign of disability. You can check the plantar and reflexes and all, pupils. So D and E, always expose a patient with who is critically ill, because there may be some, like a patient might have fall because of this after this event or before that event, or you may see some bruises because of that, or there could be some other thing. You may see that there is a pacemaker, or there is a fistula, or there is whatever it is, like you may see something like that. So you must expose your patient once. And now this is basically how to approach such patient, any critically ill patient. It is for any critically ill patient. If one comes, first what you have to do, you have to just while going to approaching the patient, first see whether the patient is conscious or unconscious. If the unconscious, you have to first do the basic life support assessment with consciousness level, pulse and breathing is there or not, and accordingly. If the patient's pulse and BP is there, then and if it's not there, of course you have to, it means there is a cardiac arrest, you have to do with the ACLS protocol. And if it is like, if the patient is unconscious but there is pulse and breathing, so you can approach towards the primary and secondary assessment, or directly if the patient is conscious, you can approach to the directly primary and secondary assessment. In primary assessment ABCDE, in secondary assessment sample history to find the differential diagnosis you need to do. So and so in sample history, just see the sample, so it becomes so easy to understand. A sample history, sample S is sign and symptom. What sign and symptoms has happened because of which the patient has been brought here. So here the patient with generally the hemorrhagic stroke patient will have acute sudden loss of focal neurological deficit will be there, and there could be some giddiness, headache, or slurring of speech, aphasia, or patient will having difficulty in seeing, or some gait disturbance like that. So in sign and symptoms will be this, and then you will see that sign, you will see that there will be hemiparesis, and there can be pupils can be unequal, plantar can be mute, or extensor. So these signs. A you have to find for any allergy. M is for medications. So with which medication patients were on, maybe having like marked bradycardia, maybe the patient is on some beta blocker, maybe the patient is not taking medications properly, is hypertensive or not taking, or it has not been diagnosed, the hypertension has not been diagnosed, or there is some history of taking. And so the possibilities is that patient is on some anticoagulant or antiplatelet because of some other reason, maybe having DVT or some cancer, or some any reason which requires, or is CAD, post PTCA, or whatever. So we should know that what are the medication patient is on. So SAMP, past medical history, as I have told you, that that can help you to know that whether what are the risk factor. Maybe patient has a history of amyloidosis, having some AVM, vascular malformation in the brain, or maybe having some malignancy because of which there is a metastasis, or maybe primary malignancy in the brain. So these all can help you to know what is the help you to go to a diagnosis or help you in treatment. So MPL, L is last meal. Why it is important? So these patients can present in a comatose or stupor stage, or we may have to protect their airway. So like for rapid sequence intubation, or for putting advanced airway, we must know that when the patient has taken last meal, and what type of meal he has taken. Liquid has a different gastric emptying time, and solid has different. So we must know. So last meal, PLE. Event which has led to this, what the patient was doing before this has happened, whether there is a history of some trauma which has led to this hemorrhage, or whether there is like nothing has happened, has spontaneously the patient was just sitting and suddenly he said that this has happened. So there is the cause will be differ if this is spontaneous or whether it is traumatic, isn't it? So so we have, for any critically ill patient, just see for the primary and secondary assessment and reassess every time. So now come to how to go approach a patient, like what will be the management. The risk, start with the risk factor. These patients generally they are hypertensive, or maybe undiagnosed hypertension, or there is some patient is on some anticoagulant. These patients will be old, male, hypertensive, history of cerebral amyloid vascular disease, some, or maybe having some coagulation disorder, or taking some anticoagulant, or having AVM as I have told you, or some primary or secondary metastasis, hypertensive vasculopathy, or vasculopathy because of some other reason. So these are the risk factor. Now sign and symptoms already have told you, and then we have what is the diagnosis, like imaging of choice. So either it could be CT scan, it could be MRI, because CT scan well captures basically any focal neurological deficit. We need to rule out whether it is hemorrhagic shock or not, and that can be ruled out just by doing a simple plain CT scan. And if we do MRI, we can get other information also, and more clear picture of posterior fossa and brain stems. So that is helpful in that. Otherwise CT scan is fair enough. It is as good as MRI brain to see for whether it is a hemorrhagic or hemorrhagic stroke or not. So focal neurological deficit, it is stroke, or it could be some stroke mimics. So stroke mimics can be seen better on MRI, of course, but to see whether it is a hemorrhage or not, if it is a hemorrhage weak and focal neurological deficit means is a hemorrhagic stroke. Now if it is no hemorrhage means there is some thrombotic acute ischemic stroke. So acute ischemic stroke, you have to thrombolize if in window period. So that is why we need to rule out whether it is hemorrhagic stroke or not just by doing a CT scan if we can't do MRI brain. MRI brain can also help us in finding out the other causes, and followed by we may do CT angio or MR angio or DAC to find the cause of hemorrhage. So that can be done after later, after the initial management. Now what to be done next? So these patients, if after ABCDE, you have to keep the head of the head in the neutral position to minimize the raised ICP, and at the 15 degree head should be placed, and don't put anything in like to hamper the flow. Don't put a central line in the internal jugular vein, because of course it can decrease the flow. Better to put other places, that we can avoid neck vein cannulation, that can be avoided. Other than that, we have to monitor do things for the raise to decrease and raise ICP, like if there is we can use hyperosmolar agents like mannitol or 3% saline. Of course in this ESRD patient we can't give mannitol because it is not going to help in this, because although it is a hyperosmolar agent, it will draw the blood from the cerebral cells and interstitial cells and put it back in the cerebral vessels, but it will not get excreted in the kidney. So there will be increase in intravascular pressure. So continuously there will be we have to do dialysis ultimately. So 3% NS can be helpful in this. It is basically to buy time and or if there is a sign of elevated mass effect or midline shift, and we are not going for the surgery, or surgery is not indicated, or we are managing it. It is managed. We are managing it conservatively. It depends upon the mass effect basically, and size and perilesion edema. Accordingly, mannitol or 3% NS is decide. So we have to, as I have told you, decrease the BP. Don't the antihypertensive agents we should use which doesn't increase the cerebral blood flow, like NTG and nitroprusside should be avoided, because it causes as along with the systemic vasodilation, it also causes cerebral vasodilation, which can further increase the intracranial pressure. So dihydrocalcium channel blockers are preferred. nifedipine should be given. Labetalol, that is a beta blocker and alpha 1 blocker, that can be given. If you have a concern of bradycardia, then you can go with calcium channel blockers, dihydropyridine calcium channel blockers, IV medications, because it can be titrated accordingly. And the long acting should be avoided, because you don't know, like its predictability can't be, we can't predict it, how long it will take to bring back the BP down and all. So it's better to titrate with IV calcium channel blockers or beta blockers. So next, along with the BP control, next is seizure prophylaxis. Should we give seizure anti-convulsant in all? No, it is not indicated in all, but there is a chances of seizure, and if seizure happens, or so in that case anti-epileptic should be given. Although most of the centers are giving anti-epileptic, even prophylactically also, and that depends totally upon the neurosurgeon and neurologist experience. So next comes, so we have controlled the BP, we have talk about the anticonvulsant. Yeah, let's talk about the coagulation correction. If this patient, suppose there is like we have to hold all the antithrombotic or antiplatelet agents whatever the patient was on, because the bleed has happened. So bleed, so if required we have to reverse it. Like in this patient, if this patient has come after 1 hour of heparin, received heparin during dialysis, we may have to give protamine, but this patient has come around after 18 to 20 hours of heparin, received heparin, so it's of no use to give any protamine. We did APTT also and it was normal, so we didn't have to give in this patient. If the patient was on warfarin, we have to give vitamin K, FFP or factor 4 PPC. If the patient is on DOAC, newer anticoagulant, so we have to give. Then if the patient is on rivaroxaban, apixaban, we may have to give androxanate alpha. If dabigatran, the idarosuzumab, that is the antidote, we may have to give that. So according to the anticoagulant which patient was receiving, we may have to give the antidote, or accordingly we have to give blood products accordingly. So all these things are there. So size and site of the hemorrhage matters. When although we have to give to for every such internal ICH, we have to give neurosurgery reference, and generally patient get admitted under them only. But when surgical intervention is must, it's if the hematoma size is greater than 3 centimeter, and with if it is intraventricular bleed with hydrocephalus, if there is a cerebellar bleed with brainstem compression. So these are the time when, or there is a large bleed with midline shift with Mars effect. So all this time we have to go for decompressive craniotomy, and all depends upon the patient overall condition. Only putting in posterior fossa bleed, only putting intraventricular drain is not sufficient. It is not recommended. Generally along with the posterior fossa decompression you have to put that. So these are the things we have to closely monitor. The patient can deteriorate anytime. If you find the GCS is coming down, you will have to do CT scan or brain imaging to check for the rebleed. So generally the initial size of the bleed, and if there is a heterogeneity, or if there is extravagation of contrast, if we are doing contrast here or in angio, so we can see that if the bleed is, if it is heterogeneity means still bleeding is going on. So these are the risk factor of expansion of hematoma. Thank you.